All right, so as usual, I try to present the latest data, which has happened in last 1 year. So you see the 6th, the June 2024 to 25. Nothing before what I showed, not even a single slide except the first introductory slide of the Andreas Grunswick, which I always start with because of he started this field of interventional cardiology with the balloon angioplasty, as you see. Even that worked quite a well from 1939 to 1985. And dream was the catheter-based percutaneous treatment of vascular disease in alert and awake patients. And of course, we have come a long way with utmost safety, appropriateness, and ambulatory. So those things I have put now. As you know, 60% of cases, patients who are non-acute coronary syndrome are discharged home same day after 3 to 8 hours of observation, and they do extremely well. So procedure has become real ambulatory, what was his vision was. His second vision was do one, look, see one, and teach one. So means continue to explore and expand the field of interventional cardiology by attending the seminars and then learn from them, do yourself, and then teach others. That's what he used to do, the workshop. It started with the initially San Francisco, but then went to Emory, where there is a whole Andreas Grunswick lab is there, and used to have like setup doing the procedures, and people used to look around, attend his symposium, conferences, and go back and start doing the program in their own field at that time. Remember that time was nothing though distant, little balloon, and you have to talk to the company how to make it and supply to your center. And now we have gone that far that multivessel disease, left main, do a PCI, and patients are discharged the same day. So goal will be to put some relevant the articles which have changed our interventional practice. Now, first one is the MCS, which is the mechanical circulatory support in cardiogenic shock. So there are few trials, the danger shock, ECLS, and alt shock, which is the IABP. These are the 3 devices which we use. As you can see, the balloon pump, middle is the Impala, which is CP, and as well as 5.5, and CardioHelp is the portable ECMO. So most of the labs in the country, even my hospital back in Jaipur, we have ECMO in the cath lab, because if catastrophe happens, ECMO is the one which takes you out from the catastrophe. But cardiogenic shock is a little different, and the data which I am going to share is the ECLS shock with the 1-year data showed patients with a cardiogenic shock with MI using the ECMO, there was no benefit in every aspect, even early recovery or mortality at 30 days or at 1 year. So we had a little disappointment, but we still use ECMO. Many times used as a last resort, but from the data point of view, trial was negative. Second is the Impala, which is called microaxial flow pump, MFP, started with Denmark, but then they did the Germany and took about 10 years to complete the trial. This is about 360 patients, put Impala versus standard of care, and what basically they found is that significant reduction, 13% reduction in mortality. But look at that now. Even this day and age, our mortality of cardiogenic shock is about 45-50%. So just to say there is a lot to be done, desired in this area. But more importantly, the 13% reduction, and the question was replacement therapy. No, it doesn't protect kidney. There are some data in the past. But more importantly, look at the vascular complications. High, bleeding. Why? Because the sheath size is 14 French. Now, if you can bring that sheath size to 9 French, and we know the bleeding patient dies, if you can decrease that, the benefit may even be more pronounced. And that's what we are working with now. At present, 4 companies, we are in the 4 trials using 9 French sheath compared to 14 French. And your balloon pump is, balloon pump about 7.5, and PCI we do with a 6 to 7 French device. Then the balloon pump, another trial, it is called Alt Shock 2, from Italy, the balloon pump in cardiogenic shock in the heart failure patient. So there was a lot of data, the ECMO can work, and these are the patients who, about 100 patients, balloon pump versus pharmacological, and basically showed no benefit. As you can see here, identical endpoints, actually balloon pump may be a little higher bleeding rate, but overall from mortality point of view, no difference at 60 days. So just to say, balloon pump in heart failure, causing cardiogenic shock, no benefit. And so therefore, now what happened to these, what is happening in the country? ECMO, balloon pump, and Impala, they all are increasing. Now, ECMO is increasing despite no negative evidence. And of course, the balloon pump is still increasing. The biggest change actually has happened in ECMO, and now the Impala. And Impala is going to continue to increase with the decreasing sheath size. And overall, I would say, the volume-wise, which I have said, the ECMO 2 plus, 1 plus balloon pump, and 3 plus for the Impala in going forward. Then there is a very interesting paper from our group, because when we do PCI, the MI occurs because troponin or CABG elevation. So we call procedural MI. Now these patients, after recover, go home and they develop MI at the follow-up. That's called a spontaneous MI. Many of the trials have shown that PCI decrease the spontaneous MI because you revascularize the vessel compared to you continue medical therapy. That has been shown in many trials, like even ischemia trial, which is the compared revascularization with medical therapy. So therefore, is there a differential prognosis of the procedural MI, which happen in the hospital, versus spontaneous MI? And that was the purpose of this our observation. And of course, various levels of troponin elevation, we made less than 1, 1 to 5, 5 to 35, more than 35, which we call large MI, when it is more than 35, and so occurs in about 1%, 5 to 35 occurs in 4% of cases, but very important on the right side, that no MI, and then you have the MI with the procedural MI and spontaneous MI. That spontaneous MI has a triple mortality than procedural MI for similar degree of troponin elevation. So that's a very interesting finding. And so as you can see here, that every aspect of the spontaneous MI has an odd ratio of mortality. But if you go to the procedural MI, only the large MI. Large MI means you did a bad PCI. So some CK troponin elevation, which has become now no longer routinely measured as the NCDR as well as the state, but many people do. But just to say, procedural MI, unless you have really killed one branch or distal dissections and major complication occurred, some procedural MI is a part and partial of the procedure and does not translate into the follow-up mortality. Now, why that's a difference? Very simple, because when procedural MI, patients are being watched in the hospital. If anything happens, you take care of them. And many of this occur because of the diffuse disease or as a type 2 MI because of the tachycardia and hypertension post-procedure. Then the field of drug-coated balloon. Another drug-coated balloon trials have, every few weeks you hear about the new, and all device companies are coming up with a drug-coated balloon in the coronary artery. And what is a drug-coated balloon compared to a DES? DES has the drug on it and the stent is there. But drug-coated balloon, the concept is that drug is impregnated on the balloon. And with a special nanotechnology, when balloon is inflated, it goes into the arterial wall. Based on the lipophilic action, it stays there. And of course, continues to have the process of the anti-proliferative. All the drugs which we use for DES have been used with the balloon. And biggest advantage of it, since there's no stent, you don't worry about the endothelialization, so short depth. And also, there's no additional metal. You don't block the side branch, maybe less inflammation. So many of the advantages, there will be no stent thrombosis because there is no stent. And this is actually have been looked into it both the ISR group as well as in the de novo group, as you can see here. The one which has made to the final is the agent balloon of the Boston Scientific, approved by FDA, except it's very good based on the trial of the agent trial showing against balloon angioplasty in patients with ISR. They're having a lower event rate using the agent DCB compared to balloon angioplasty, except the cost of the device is very high. It's a $5,500. You know, regular balloon is $150. So now you say, okay, America will pay reimbursement. So it will happen. So that's America is all about. The healthcare costs keep going up because we bring the newer device, we improve the outcome, but we don't improve the financial outcome of America. That's where now same device, the 5,500, is available in the Europe. Guess what is the cost? $200. But America, because that so much cost, they have to spend $100 million to do the trial. So finally it goes to this, that was budget, the price, and it's been approved. So some Medicare and some private insurances have approved it, but it's a good device to use, particularly for the ISR cases, and you can see, as I said, no stent thrombosis. So then question was, we understood the ISR works. What about in the native vessel? If you got a good result with a balloon, and if you put a drug-coated pre-preparation of the lesion with a balloon, cutting balloon, rotablation, you open the vessel, now should you do the DCB or should you put a DS? That's a major question. This was the RAC cage-free 2 trial done in China. They have paclitaxel special drug-coated balloon and Firebird, their sirolimus eluting DES. The concept was you did a patient came with a lesion, native vessel, all vessels, small or large. You do a good balloon, looks good. Now you randomize DCB or DES. If not good, then you put a DES. So we understand that the DCB comes in only when your lesion looks good after your initial preparation. And what they found, basically not good. In a native vessel compared to what we have in the ISR group, as you can see, DES group has a lower event rate, the red bar compared to the blue bar. So all event rates are much higher in the DCB group compared to DES group, and actually it happens to be even a little better in terms of the mortality 0.06. The difference actually happened because in the large vessel, you see the large vessel event rate is almost 1/3 in the DS group compared to DCB. In the small vessel, on the left side, no much difference. So basically, what the message is, in a small vessel, if you want to use DCB, except the cost, no difference. In an in-stent restenosis, very good. In a large vessel, not indicated. Exactly that was the conclusion, that in the large vessel, or otherwise also, overall, if you want to think about, DS should remain the strategy, and this is where we do optimal lesion preparation. This pointer does not work. Okay. So optimal lesion preparation, which in the center, oh, sorry, we got it now. So once you have optimal lesion preparation, pre-dilate, looks good, whatever you need to do, acceptable angiographic results on the left side, then you can go with DCB. If suboptimal, you put a stent. So strategy is, once you have opened the lesion, well, the question is, can you have a stent-free strategy as good as your stent? So that's the concept going on at present, and what has come out to be, it works in the DS-ISR, a small vessel, the side branch, and particularly patients who are bleeding depth and so. So those are the cases which we use. Imaging is a big field, and now a lot of studies have been done using various types of imaging with the physiology as well as imaging with the IVUS, OCT, NIRS, and the many trials which have made that became part of the routine. And these are the various trials in various aspects. You imagine in the last 4 or 5 years, we have done probably 20 plus trials, around 15,000 plus cases in the imaging trials to show whether imaging are good. So many of them have been presented before, and the one which I want to just share this, OCT, particularly in the complex lesions, which are the CTO, bifurcation, long lesion length, OCT guided versus angio guided PCI with a 12-month design, 12-month follow-up, clear-cut criteria of the OCT in these patients, that your full stent expansion, avoid dissection, need to be taken care, and based on that, we found another trial positive of 2024-25. Before that, as I said, many trials positive, and lower MACE rate, lower revascularization, and lower, in this trial did not show stent thrombosis lower, but most of the trial have shown stent thrombosis half by using the imaging. So imaging clearly has become the part of our the armamentarium and should be used. Another one with a drug-coated, which I just said. What about the imaging? Is imaging going to add to the better outcome of the drug-coated balloon? And this is the Ultimate 3 trial, which showed, yes, even angiographic guidance versus IVUS guidance have a better lumen and the lower event rate in the drug-coated balloon also. Not only DES, drug-coated balloon also. Now, Greg Stone put the meta-analysis of all the trials. Actually, this is putting it because it just came out in the Lancet. This was a slide I did share last year also, just to say, on the right side, every aspect of our intervention. By using the imaging, you decrease it by 25 to 70%. And the most important is in the center, stent thrombosis become half. And that's the trials after trials have shown. And of course, at present in the America, 75% is IVUS, 25% is OCT, and it is used in about 1/3 of the cases in United States. Now, this is the data about 6-8 months old. I'm sure with the recent one, it may change even further because two guidelines, European as well as the ACC guidelines, have supported as a class 1 indication, particularly in acute coronary syndrome, as well as in the complex disease being left main, long lesion, bifurcation. That's what we'll be using on tomorrow, and imaging will be the center part of it. So since imaging is to the level, as you know, many of you have seen our CCC live, myself and Dr. Keeney felt that we need to have a more dedicated CCC live webcast, confined and basically concentrating on the imaging, on the various aspects of imaging. So it's started, done the 2. So remember, second week we do a structural, second week usually Tuesday, a structural heart. Third, we do a coronary webcast. Fourth, we do endovascular. So we left with 1 week, first week to fill. So first Friday, they started 2, one was done just a few days ago, is the imaging conference, dedicated on various aspects of imaging, and with the involvement of course, with Annu, with the Amithuda and Kiski. You'll see him, of course, later today also, but during the cases tomorrow, and moderated by Nitin Barman. So imaging has become to the center stage of intervention cardiology. Then plaque modification. So usually more than 60-70% of cases, there is a blockage, you do balloon open, put a stent, and done with it, and life goes on. But what about various technique of plaque modification? So one of them, the trial was the severely calcific lesion, whether imaging helps in severely calcified lesion also. This is the Target 3C trial, and about 120 patients, comparing with the angiography, OCT, and the IVUS, and basically showed that by using the imaging, OCT guidance, IVUS guidance, malposition slightly lower, and the late loss, means how much you lost at a follow-up, the imaging have a lower late loss because you are able to open lumen better, as you can see here in the bottom. And then restenosis rate, although was not different in this small study, but overall it says that height of both the blue and yellow bar is lower than the angiographic. So clearly it helps it, although not overall significant because of a small number of cases. So imaging improve the stent outcomes in terms of the morphology. Then the trial was roller coaster EPIC 22 trial, which compared rotablation, IVL, and laser for the calcific lesions. As you can see here in the bottom, that clearly the rotablation and IVL are similar in terms of their outcome. Laser is not good. Complications are about acute procedural success in the center is about the same, and more importantly, complications are comparable, but IVL has no complications. See the 0 on the right side. So key is the IVL, which is the shock wave, very successful, very good device, and has almost no complication, and that's what use is increasing now. About 7-8% of our interventional cardiology patients, PCI, are done using IVL. In the country, actually, some places almost 12%, and so. Then, what about you have stent restenosis? You do rotational atherectomy. Few trials have been done in the past, ARTIST, and we did a trial also, but question was, doing the rota? Answer is no. You can see the height of the blue bar versus red. The rotational atherectomy has a higher complication compared to the red. So overall, rotational atherectomy is no good for the ISR. In some cases we do if there is unexpanded stent and so. Then the Calypso trial was that whether OCT improves the outcome in calcific lesions, and answer is by improving the lumen, it definitely does. As you can see on the left side, OCT guidance, MSA, minimum stent area is higher than compared to got with the angiography, and more importantly, stent expansion and malposition, lower with the OCT compared to angio. So calcific lesion imaging continues to show. Then we have a major trial to look at the orbital atherectomy versus balloon angioplasty in calcific lesion called Eclipse trial, which was presented last year and basically showed no benefit of OA. The orbital atherectomy is one of the device along with the rotational atherectomy which grinds the plaque. And it showed this trial no benefit at 12 months of follow-up, slightly better lumen in the orbital atherectomy group compared to, but there's slightly higher complication also, more perforation, more slow flow, and imaging group. Within there, in the OCT, which was done in about 2/3 of cases, the outcome was much better compared to the non-imaging group. So again, points to be that in the calcific lesion, imaging have a better outcome compared to no imaging. And overall, as I said, the trial was negative. Even stent thrombosis was slightly higher in the orbital atherectomy group compared to balloon angioplasty, as shown there. Then the question was, the next question, the senior Rita trial, that invasive strategy for older patient, older MI. We know that the patients who are younger age, we always take them to the cath lab, but what happens to the patients who are old and non-STEMI? STEMI patients, irrespective of the age, has been shown to benefit. So if you are old, and then what you do, whether you do a non-STEMI patients, should you do a PCI on those cases, take them to a cath lab or not, 75 years and above, trial done in the UK, look into this aspect of the 75 plus non-STEMI, randomized to conservative and invasive group. You see there, in the invasive group, 90% went to the cath lab, but PCI was done only in half. Why? Because the non-STEMI compared to STEMI is a diffuse disease. And therefore, those patients don't do well with the PCI. So even investigator, after doing the angiogram, did PCI only in half of them. And of course, in the conservative group, 6% failed through the medical therapy, went to the PCI, cath and PCI, and outcome was identical. So what is the message? Basically, death and MI. As you can see here, and the bleeding actually was non-statistically higher, but overall at a follow-up of 5 years, non-STEMI invasive strategy did not work. So you can make it a point that not to take these patients to the cath lab and just treat them medically. Then the colchicine. Colchicine, a lot of trials have shown that colchicine is better in patients to reduce the MI, reduce an angina in the stable CAD patient. And then the major trial was done called CLEAR Oasis 9 colchicine. These are the newer anti-inflammatory agents, and it basically work on the microtubules, so prevent the proliferation of the endothelial cells. And earlier trials, the Colcott, Lodoco 2, and the meta-analysis all have shown that overall colchicine use was beneficial. So see, that's all happens. You do multiple trials, all looks good, and now all of a sudden you have another trial which asks us to forget whatever we learned in last 5 years. And this is one of them. The Oasis 9 Clear Synergy, patients who had MI were randomized to colchicine. This was a double 2x2 factorial design, spironolactone versus placebo, colchicine versus no colchicine, 2.5 milligram started within 2 to 3 days after STEMI PCI, and most of these patients had the DES. What it show, inflammation point of view, CRP, colchicine did a better job, decreasing the CRP levels, as you can see here, compared to placebo. So CRP did decrease in the more colchicine group, but at the outcome, 5 years, exactly identical outcomes, no difference. So whatever we learned in last 6-7 years on the trial, all gone. Primary outcome, exactly identical. Primary, secondary outcome, colchicine, no colchicine, all the same way. Rather, there were more diarrhea, more GI symptoms with the colchicine. It's a 0.5 milligram, not the usual our 0.6 milligram, which is available, it's 0.5. And then actually, this available now with the name, very, proprietary name, but it's very expensive at present. The Lodo, 0.5 milligram tablet, but otherwise you can give 0.6, which is available. And we think the reason is because colchicine decreased the release of the VEGF, and that probably is the reason why it did not work. So maybe because it was given very early. At the time you did a PCI, you want the vessel to heal, but some of the activity of colchicine is against it, and particularly preventing the vascular smooth muscle cells. So the healing process was inhibited. That likely was responsible for this. Now, the field is not done yet. So they did now that what about plaque volume? They call Ekstrom trial, the patient with the colchicine progression of the atherosclerotic plaque. A small number of patients, but shown as on the right side, as you can see, colchicine decreased the plaque volume. Not the acute plaque, but other plaque, calcific plaque, all were decreased by colchicine. So this field is not done yet. I'm sure people will continue to do more studies to answer this question. Then the FFR is the invasive physiological measurement. Anything less than 0.8, we intervene. More than 0.8, we do medical. And of course, a major trial, which was done, FAME3, compared FFR-guided PCI versus CABG and showed that at 1 year, FFR-guided PCI was inferior to CABG. Then we have the 3-year data, which I showed last year, that trend towards 0.07, death and MI, is still in favor of CABG. Event rates was higher in the PCI group compared to CABG. Now you take these patients at 5 years. And this is what presented this year in ACC. 5-year data of this PCI versus CABG with FFR guided. Overall, the technique was same. And guess what happened now? At 5 years, the benefit which was there at 1 year was trend at 3 years, disappears at 5 years. And these are the numbers. So death, MI, or any stroke, identical, no difference at 5 years. So what does that mean? So I think you can say patient has a limited lifespan. Even with any kind of CAD, PCI will do a good job of prolonging life for 5 years and individual endpoints here. Only was that you have a higher repeat revascularization, which we know always happens. And of course, simpler the lesion, low syntax score, PCI did a better job. And the intermediate to high, it was more of the benefit of the CABG. Now, just to say that how science has progressed. We did a trial, syntax trial, was about 12, 14 years ago. Outcome at that time of the PCI and CABG was 14.6 and 9.2, multivessel disease. Now you take a multivessel disease of FAME3, guess what? Outcomes are half. So we have such a good techniques, just to say, improvement in overall the mortality and the death, stroke, or MI, as how improvement the science and our techniques have, the event rate which used to be 10, 12 years ago, just by default have become lower. So what were results of the bad PCI or like PCI with those, those stents, the Texas stent and Cypher, although it was only Texas in the syntax. So that outcome is now in these complex cases. So just to say that irrespective of the disease process, PCI has been done very well in the individual outcomes. Also, there is some data have pushed in the past show that 22 should be the criteria for the PCI benefit. Now it has come up with many data that 25 or 24 is the cutoff now, and the more than 25 may be bad, but 24, all patients should get the PCI. Then another question was in patient with MI, the FFR-guided PCI. This was the floor MI, 3-year follow-up, identical, no outcome difference. So in MI setting, the physiological guidance did not help much, and individual endpoints are here at 3 years. So then the one issue is always happen. You have done PCI, patient done good for 1 year or 12, 15 months. Now you do what? Do you do continue which depth, whether you continue both or continue one? And this actually has been clopidogrel or aspirin post-PCI for long term. Smart Choice 3 trial done in South Korea. Large number of patients, 5,500. After their completed duration, they continued either clopidogrel or aspirin. The height of the blue bar is clopidogrel, superior outcome. Lower bleeding, better outcomes with the clopidogrel compared to aspirin. As you can see, this is like an original Capri trial, but this is for all PCI patients. So you can make it a point that patients who are long-term after PCI should get, more importantly, clopidogrel. No difference in bleeding. And also, important was, this is not the first one. Of course, they cause more GI bleed when you take the aspirin. So aspirin we know is bad for stomach. There has been a trial which I showed about 3 years ago, host exam trial, which is also the same, wanted to study the patients who had good PCI 6 to 12 months and found that it was basically the clopidogrel have a better benefit with a complexity or bleeding patient compared to aspirin. So more and more data are coming. If you need single antiplatelet therapy in a follow-up patient, you can just use the clopidogrel and not the aspirin. So with that note, I come to the main, our advancement of the 2024-25 is the guideline update from both European Society and the European and American College of Cardiology, one for coronary chronic coronary syndrome, one for acute coronary syndrome. So 24 guidelines of the ESC, but for the chronic coronary syndrome, which we call stable angina, lot of emphasis on mechanism, understanding, and then stratifying patients based on the risk. And of course, the workup of these patients appropriately. Don't do multiple tests based on the patient's risk. You do either imaging, particularly CCT, non-invasive imaging, or but just the regular follow-up. And so this actually has incorporated in our equation. And the LDL and have a good risk factor reduction of these patients with various of these SGLT drugs, and anti-inflammatory colchicine was 2A. I'm sure it will become 3 now. The more important also that any complex case, heart team discussion should not make a single decision. Heart team discussion should be there, and imaging, as I already mentioned. And left main, simple left main has become class 1 indication. So low syntax score 22 and below, left main can have a PCI as a class 1. Complex cases still remain class 3. Another field happen is a lot of patients have continued to have chest pain, but coronaries are normal. So this microvascular field and the flow reserve problem that maybe it's a microvascular disease has really come up, which is called ANOCA, and which Dr. Sweeney is going to speak about, non-obstructive coronary artery disease. There's also a need for it. So we started imaging conference, as I mentioned earlier, every other month, followed by every other month with the microvascular testing or CFT testing of this. So clearly we continue to advance the field. As far as antiplatelet therapy, data have come that after 1 to 3 months, if you're doing a ticagrelor, you can have a ticagrelor monotherapy after 3 months is a class 1 indication. And very lot of emphasis on healthy lifestyle after PCI. PCI alone does the good job, but to decrease subsequent event, it has to be the adherence to the therapy and, more important, adherence of the healthy lifestyle. Now, ACC, acute coronary syndrome guidelines, there were not much new about it, except that what we learned already, that patients with a high-risk patient should go to the cath lab. Low risk and intermediate can be managed medically, and if they break through, then only they go to the cath lab. And the multivessel disease, STEMI, class 1 indication. In a cardiogenic shock, multivessel PCI is class 3. The very aggressive treatment of the cholesterol, as you see, particularly your LDL should be less than 55 now. Acute coronary syndrome, less than 55. I'm sure soon it will be 10. Remember 90, 70, 60, 55. Now latest guidelines are 55. European guidelines also support 55. And in the I already said, the class 1 indication, single antiplatelet therapy or ticagrelor. And again, lot of importance of cardiac rehabilitation. So cardiac rehabilitation has shown that every aspect of our interventional cardiology, particularly whether you have a stent, MI, bypass surgery, improves overall fitness, decrease myocardial infarction, some studies, even lower mortality at follow-up. So therefore, all aspects, whether it's a patient need to be patient-centric, patient need to be involved in that, weight reduction, cholesterol, smoking cessation, taking their medications, and so all are important, particularly the lipid management and so. So with that note, I conclude with which I call is the central illustration, what I spoke in last 32 minutes, sorry, I went 2 minutes above, that what we learned in last 1 year. ECMO and balloon pump in cardiogenic shock, ROTA in ISR, drug-coated balloon in large vessel, and colchicine acute MI. 2 thumbs down, no good. FFR-guided PCI in multivessel disease in STEMI, invasive strategy in old non-STEMI, and orbital atherectomy and laser in the calcific lesion, all were bad. So 1 thumb down. FFR-guided PCI versus CABG at 5 years, good. Increased mortality and spontaneous MI versus procedural MI, 1+, 1 thumbs up. Impala in cardiogenic shock, yes. IVL and rotational atherectomy in calcific lesions. The clopidogrel over aspirin, long-term post-PCI. So I think this is the clear-cut data. You need to give one antiplatelet therapy, particularly those who have stomach issues. Clopidogrel long-term has been a much benefit by 2 major randomized trials. Then drug-coated balloon in ISR, imaging, OCT or IVUS in complex lesion and plaque modification guided PCI. Everywhere it has shown to be beneficial, and more importantly, the latest guidelines have taught us our therapy, where we should go in terms of management of patients in
chronic coronary syndrome as well as acute coronary syndrome with 3 thumbs up. For us to become better interventionalists, we have only last report of 19 from the New York State. That was the last one. We are still waiting for the other new reports of the New York State, that where we are in terms of our outcome and volume. We are hoping that will come in next few months. CCC webcast, as I mentioned, has been a tremendous success from our educational point of view, besides this one-day symposium which we do. But this, the monthly, over 176 countries, 22,000 hits per month. And it is going to add, because the imaging we already got, 4,000, 5,000 within 1 month. And then the microvasculature, another 1,000 plus. So this may go to 30,000 and so above. And particularly India and United States are the top in terms of our, I would say, you can say the clientele. And then, of course, time will come, if it will be shown later, another part of the education led by Dr. Keeney and her team, various apps which are continue to evolve in every aspect to improve our daily interventional life in terms of teaching, understanding, and performing the procedure. Many times people will, while doing it, they can show the app. Many of our live cases, we show that app on one side. When we are doing the procedure, exactly what is in the app is what's being done live. With that note, I'll conclude here, and thank you very much for this good start, great start.